joining us today. So it's my great pleasure really introduce Dr. Cordina. So I know Rachel for a long time, but we haven't seen each other for a long time too. And Rachel, who is in Sydney and is 10 p.m. there, kindly had agreed to join us to give us a talk about exercise benefits for people living with a Fontan circulation. So Rachel, the floor is yours. Thank you very much for joining us.
Thank you, Rafa, and thank you so much for the invitation. I feel very honoured to be a part of this. So, as you would all be well aware, there are so many well-recognised benefits of exercise in other populations, including improved cardiac function, improved quality of life, improved self-esteem and body image. But there's relatively little data for our Fontan population. And as many of you would recognise here, our Fontan population lives with very high rates of morbidity and complex chronic health conditions and has reduced life expectancy. And there's probably a number of really unique reasons why people living with a Fontan circulation may benefit more than perhaps any other group of people due to the way their circulation functions. And so for the junior people here, I just want to remind you about what is so special about the Fontan circulation. So when we talk about Fontan, it's really the end result of a surgical pathway to palliate children born with highly complex single ventricle heart disease that can't be patched up into two ventricles. And to alleviate the mixing of blue and pink blood and that cyanosis and volume loading, the systemic veins, the inferior and superior vena cava, are connected straight on to the pulmonary arteries. So the heart is essentially bypassed. So the venous blood must return through the veins and all the way through the lungs before it reaches the heart. So there's no cardiac pump pushing blood through the pulmonary vasculature. And so the Fontan circulation relies on some different forces for cardiac filling. We recognise now that the lungs are really important. During inspiration, we generate negative intrathoracic pressure, and that sucks blood into the pulmonary vasculature. And then during expiration, the blood's pushed out of the lungs and pushed into the heart. Especially during exercise, increasingly in the last few years, we've understood that the skeletal muscles are actually really key for cardiac filling. Diastolic function is really important, good diastolic function, but probably the lungs and the skeletal muscles are the most important forces. So the bigger the muscle belly, the more blood is squeezed out during muscle contraction and back up to the heart. Now that reliance on peripheral muscle is a real concern because it's now recognised that people living with a Fontan circulation are really prone to a reduction in skeletal muscle mass that we've called a Fontan-associated myopenia rather than a sarcopenia that you might have heard about in the elderly, because that implies some kind of wasting. Whereas in people with a Fontan circulation, there's probably some developmental issues with the muscles due to the reduction in blood flow and a whole range of other reasons that we're still trying to unravel. In our group of adolescents and adults in Sydney, mean Z scores are about -1.5, with 30% of people in the sarcopenic range deficiency, and over 2/3 have a clinically important deficiency of muscle mass under -1. And groups in North America have demonstrated very similar deficiencies in children. And the muscles aren't just deficient in mass, but they also function in an abnormal way. So the ability of the skeletal muscle to extract oxygen during exercise is really abnormal. And there's skeletal muscle afferents that feed back to the sympathetic nervous system are also very abnormal. Sorry, I'm laughing because my dog has decided to wake up and walk around, if you can hear footsteps. So these skeletal muscle afferents are very abnormal, and they feed back to the nervous system and drive ventilatory responses and drive blood vessel responses and cause muscle fatigue and premature sort of weakening of the muscles. And interestingly, in 2006, this was really one of the first Fontan-specific exercise training studies, and they demonstrated that you can improve ergoreceptor function, or those little skeletal muscle afferents, with an aerobic and resistance training program. And this really piqued our interest back then, and that's how we really got into this line of research during my PhD studies. Now, body composition is very abnormal in Fontan, not just because of a skeletal muscle deficiency. Even though people have reduced lean mass, they actually have increased adiposity. And when we studied our group in Sydney, the second most common body phenotype is low lean muscle and high fat. And you might be saying, well, my Fontan patients don't seem very obese, but actually that's because the scales is a really poor way to assess body composition. And that probably also underlies why the studies that have used body mass index to look at clinical outcomes are really mixed, because it's a bad way to assess body composition. Some studies suggest that high body mass index is associated with better outcomes, and other studies suggest that high body mass index is associated with poor outcomes. There's an example here. This is two women with almost identical body mass index, and the woman on the right has a much higher body fat percentage and a clinically important deficiency of muscle mass. The woman on the left has a much healthier body composition. The ALMI-Z score, for those of you who aren't familiar with it, is one of the main ways we sort of quantify lean mass. It's the appendicular lean mass index. So the level of agreement between body mass index and more accurate measures of body composition, we generally use DEXA, but BIA is probably also a reasonably good way to assess body composition. And it's much, the body mass index and weight becomes much more inaccurate with the lean mass deficiency, because the obesity is masked by the lean mass. People don't weigh as much because they don't have as much muscle. Now, the reliance on the thoracic pump really depends on excellent lung volumes and low pulmonary vascular resistance. So it makes a lot of sense that obesity is really bad news for the Fontan circulation, and none of you will be surprised when I tell you that the degree of obesity is associated with the risk for obstructive sleep apnea in people with the Fontan circulation. And of course, obstructive sleep apnea is a really bad thing for people with a Fontan. We've looked at a fairly large cohort of Fontan adolescents and adults across Australia and New Zealand, and found that obesity was independently associated with poor outcomes in the setting of a Fontan circulation. And those people in red are people who met the failure endpoint, and you can see that all 4 of those people also had a reduction in lean mass. A really interesting study coming out of Japan a couple of years ago now suggested that in children, those who gain muscle and lose fat over time do better, or to the contrary, the children who lost fat the children who gained fat and lost muscle did worse. They had a much higher risk of failure in the long term. So I just want us to think for a little while about the factors that contribute to Fontan circulatory failure. Adverse pulmonary vascular remodeling is really important. As pulmonary vascular resistance goes up, that impedes cardiac filling. It drives up systemic pressures, leading to end organ damage. Adverse cardiac remodeling is also a really important problem that develops in a subset of our patients, both diastolic and systolic dysfunction. And we really don't fully understand the reasons why that happens, but one of the main hypotheses is preload starvation. Just like any other underutilized muscle, adverse remodeling occurs and the muscle stops working properly. And probably now we're starting to recognise that skeletal muscle wasting, which is associated with reduced venous return, reduced cardiac filling, is probably an important aspect of Fontan failure. This is just some data that we've taken from the Australia-New Zealand Fontan registry, showing that even in kids at the age of 16 with what's called normal ventricular dysfunction, quite a high proportion of them will go on to develop systolic dysfunction over time that is then followed by circulatory failure. Interestingly, a number of studies have suggested that kids and adults with a Fontan circulation who participate in sport have better cardiac function. So is that the chicken or the egg? Are the children who just are too sick to exercise, gain weight and have poor peripheral muscle mass, they've got poor heart function, so they're just not able to exercise? Or are the children who play sport, do they develop better body composition, better muscle, better fat, and have better heart function? So to really address that question, we need prospective data, and we need to work harder. There's not enough prospective data at the moment, and I'll address that at the end. But there are some small studies, and we took a bunch of adults in Sydney, Australia, and our main question was, can we augment the peripheral muscle pump to improve cardiac filling, stroke volume and exercise capacity? So we really intensively resistance trained these people for 20 weeks. It was isolated resistance training. There was no cardio training for 3 days a week. Over time, on average, they put on 2 kilograms of muscle, which is a pretty impressive increase, and body fat tended to fall. We weren't trying to burn body fat with this study, and actually cardio exercise is a much more efficient way to reduce fat, and one of the reasons why we think probably in practice we should be incorporating some cardio exercise into our training prescription. After 20 weeks of exercise training, peak VO2 increased by 10%. At free breathing MRI, in the trained state, stroke volume was higher. And when we looked at the cardiopulmonary exercise test data, the oxygen pulse, which is a surrogate measure for stroke volume, improved early on during work and became much more pronounced at peak exercise. And we hypothesised that the most likely reason for this was that gain in skeletal muscle mass and improved preload. A number of groups now have wondered whether, well, if the skeletal muscle pump's important and the thoracic pump's important for cardiac filling, how about we try strengthening the thoracic pump? And so a couple of groups have reported inspiratory muscle training without any exercise training and have found some modest benefits for peak exercise capacity and improvements in stroke volume, but they have been modest, not at the levels that we've seen in exercise training. But importantly, traditional exercise also naturally strengthens the respiratory muscles because of the hyperventilation that one does as an adaptation during exercise. Now, this adverse pulmonary vascular remodeling, I'm really interested in, and it's quite difficult to study this as an endpoint, but increasingly we're recognising that the pulmonary vasculature is very, very abnormal in the setting of the Fontan circulation. And that's probably because in the Fontan circulation, the pulmonary vasculature is not subjected to pulsatile flow. So this black panel here is just a pulse wave Doppler I've measured in a young woman with an extracardiac Fontan. I've got the pulse in the main pulmonary artery, and you can see there that the flow is just slow and laminar, and it's increasing with her inspiration. And this lack of pulsatile flow probably affects the pulmonary endothelium because nitric oxide and the endothelium works by shear stress, which helps it to function properly. This is a picture of one of our registrars who kindly let me measure his pulmonary blood flow with Doppler, and you can see that it's just completely different profile to somebody living with a Fontan circulation. Now, not only is the endothelium dysfunctional because of this lack of pulsatile flow, but also when we take away pulsatile flow at the time of Fontan completion, pulmonary artery growth either slows off or completely stops. So that stretch and strain on the pulmonary vasculature is also very important for pulmonary vascular development. But it is possible to change the flow profile in the pulmonary vasculature of somebody with a Fontan circulation. They just need to exercise. So in this picture, I've put the ECG leads on this woman's leg so that you can see when she's pedaling on the bottom. And you can see there with each leg contraction, there's a pulsation being pushed into the pulmonary vasculature. Now, this is just hypothesis generating at the moment, but it's really interesting to think that during exercise, flow naturally goes up in anybody that exercises because cardiac output improves. But some people with a Fontan circulation can even generate this pulsatile flow profile. And I wonder whether this underlies partly the reasons why some of our people living with a Fontan circulation who are exercising regularly just seem to be doing so much better than many others. I've spoken to a lot of other specialists about this, and we all have recognised this particular phenotype that we've called the super Fontan. People who have been active even from when they were little kids and played a lot of sport, and they just seem to be so much healthier than the people who are inactive. And we've studied our little cohort of super Fontan. Usually, well, we've found, and others have reported, around 10% of people have a normal or even supranormal exercise capacity. And when we delved down and looked at what is it about these people, really there was a whole bunch of things that we usually consider to be adverse, like pacemakers, Fontan conversion, atriopulmonary Fontan. But the common feature was regular participation in moderate to vigorous sports. And subsequently, a number of other groups have published very similar findings. This common feature of sports participation and being active is associated with this much better exercise capacity. Now, you might be a little bit skeptical about some of the physiological things I've talked about today, about some of the possible benefits for exercise in the setting of Fontan physiology, but there's very little question, at least, that exercise training does improve peak oxygen uptake or peak exercise capacity in the setting of a Fontan circulation. And that's really important because improving peak oxygen uptake over time is probably associated with superior clinical outcomes. The data suggests that people who can maintain their exercise capacity or improve it over time do much better than those that can't. And to date, looking at all the controlled trials of non-invasive therapies in the setting of the Fontan circulation, exercise is the most effective therapy. So I've just summarised here the major sort of Fontan-specific trials, and they've investigated a range of exercise interventions. We were the only ones to investigate isolated resistance training, but you can see there the improvements in peak VO2. But improving exercise capacity, prolonging life isn't everything, and we want to help our patients to live better and to live happier. And exercise training is a really fantastic way to improve perceived health, improved quality of life, improved one's sense of wellness. And I think for many years we've really underestimated the impact of the physical restrictions that we've placed on our patients, and I think that's been really damaging. And that brings me to this big question: is exercise dangerous? So to date, there's over 240 people with a Fontan circulation reported in the literature who have undergone exercise training with no adverse events. And as we've gained more experience routinely exercise testing people and pushing them to their maximum, we recognise now that with appropriate screening, arrhythmia is not a major concern. I've heard people at meetings say that they think that exercise is probably damaging for heart function. There's really no evidence for that at all. And in fact, the preliminary evidence suggests that exercise training is actually good for cardiac function in the setting of a Fontan, probably because of the improvement in preload. The big question that I think still exists is, does exercise accelerate liver disease? So during exercise, because the pulmonary vascular resistance really acts as a bottleneck, during exercise as flow goes up and blood is pushed towards that bottleneck, venous pressure goes up, and it can go up quite high. And so the question is, do these transient increases in venous pressure damage the liver in the long term? Or for the reasons that I've talked to you about now, that overall improved physiology, is that actually better in the long term for organ function? And there is a little bit of evidence to suggest that perhaps it does. In this Japanese cohort, people who became fitter over time, presumably because they were exercising and becoming more active, their liver function improved over time, their renal resistive index went down, and their central venous pressure went down as well. So if we had a wonder drug that improved Fontan physiology, improved exercise capacity, improved perceived health, mental health, quality of life, and preliminary evidence suggested that it improved clinical outcomes, I think we'd all be jumping for joy and prescribing it all the time. But I just don't think that we're all prescribing exercise quite as vigorously. And I want to talk to you a little bit now about screening and exercise prescription for our Fontan population. I apologise, this is probably going to be really boring if you're already super familiar with how to prescribe exercise. It may be a little bit simple, so I won't be offended if you log off now. So the first thing I do when I see a patient and I'm going to talk to them about exercise is weigh up which risk category they fall into. And it goes something like this. So ventricular function, is it normal? Is it mildly impaired, moderately impaired, severely impaired? I look at the aorta. Is it obstructed at all? Have they had a coarctation repair? Is it dilated? Is there any outflow tract obstruction, and how are the valves working? And history of arrhythmia is also really important. And of course, you weigh up these things, and if anybody's falling into the higher risk category, that's the level that we would tend to prescribe their exercise. People, the rare people who have a right ventricular dependent coronary circulation may be at a little bit more increased risk. We really don't know, but I would be very cautious about screening them properly before you send them off exercise training in the community. So a structural assessment is important with echocardiography and an MRI from time to time, in keeping with international guidelines. Generally, in any adolescent or adult, would undertake exercise testing before I prescribe the exercise program, but that's probably not necessary in children, and of course many children won't be able to perform an exercise test. And a rhythm assessment from time to time. It's one thing to look at the rhythm on an exercise test, but at least every couple of years a rhythm assessment with something like a 24-hour heart rhythm monitor. A little note, from time to time we'll come across a patient with a VSD guarding the outflow, with the aorta coming off, say, a rudimentary right ventricle. And at rest, the VSD really doesn't look restricted, but it can be very dynamic. And I'd encourage you to just be a little bit cautious. And from time to time, we have picked up with stress echo quite important dynamic outflow tract obstruction. And if that's severe, it's something that probably needs to be addressed to help that person maintain a healthy circulation in the long term. Education is absolutely essential, and we worked really hard in Australia through the Fontan Registry to educate as many people as we can about the benefits of exercise. We hold annual education days and are always talking to them about a healthy, active lifestyle. And there's also webinars that they can watch linked to the registry. It's always important to understand what somebody likes and hates. If somebody hates going to the gym, it's very unlikely in the long term they're going to stick with that. And what kind of resources do they have? Do they have access to team sports or a gym membership, or do they have the resources to have a professional trainer, or do they have nothing? And you can definitely work with nothing as well. I really like using resistance bands. So this, in this picture here, is a gym stick, and there's all sorts of cool resistance exercises you can do with something like this that costs about $100, and there's a million YouTube videos to watch. But less expensive are simply the elastic bands that you can buy off the internet that still enable you to do lots of efficient exercise resistance training at home. Of course, someone's current level of ability is really important to take into consideration, and trying to understand what the whole family is doing at home and how much screen time people are having. It really goes without saying, involving families for children is absolutely essential, and trying to cultivate habits from very early in life. We now, at the time we're talking to families about Fontan for their children, make it very clear how important we think it is that they maintain an active lifestyle. And that's really important too for managing parental fears. It's very hard for us in our teenagers and adults to undo decades of fear and being told to, not to exercise. It's also important to work out what's going on at school. Not uncommonly, when I'll meet teenagers, they're being sat on the sideline during school activities, and they, so embarrassed and feel so terrible at sport and think that sport's really dangerous. Unraveling all those things is really important. And for children, game-based sports, doing things with the family is really key. And for children who find it difficult to keep up with team sports, things like dancing, martial arts and rock climbing are things that they can do on an individual level and not feel that they're being left behind. In adults, I don't think there's enough evidence at the moment for us to think there's a magic formula. I try to prescribe a mix of aerobic and resistance training, but if somebody loves particular sports, I just encourage them to keep doing that. But if we're going for gym-based activities, I'll plan a schedule of around 50% cardio, 50% resistance. I don't think a heart rate monitor is essential, but it can be useful if you're really tightly training somebody and wanting to make sure they're meeting their targets. But I think mostly it's important for motivation, and people who are tech savvy and like their smartwatch really enjoy, I think, seeing what heart rates and levels of activity they've been getting to. In general, we aim to reach above 150 minutes of exercise per week, or around 30 minutes most days of the week. And at least 2 of those sessions, we should try and incorporate some resistance training. So we start low and slowly increase. It sounds silly to just write on a piece of paper an exercise prescription like you would for a piece of some medication, but actually there's a reasonable amount of evidence to suggest that actually giving somebody a written exercise prescription increases their activity levels. And I just will talk to you briefly for a minute about things to take into consideration when you're doing that. The frequency, so how often, what intensity, and that's based on your risk assessment of the patient, for how long and what type of exercise. So when you're thinking about intensity, there's some very simple ways to do it. And this is intensity for cardio or aerobic exercise. You can simply use the scale of perceived exertion. So if you want someone to be doing a moderate intensity exercise, in general, they should be able to speak in a sentence, but they're puffed, but they can finish a sentence. Or some people say that you could speak in a sentence, but you'd find it difficult to sing. So anything under that where you could easily speak in a sentence is more light exercise. So that's a pretty simple way to be prescribing exercise intensity. Or we can get a little bit more scientific about it. And most of the guidelines will give you a table like this, where there's thing called the heart rate reserve or the heart rate maps method to assess peak exercise capacity. And I'll talk to you more about that in a moment. So those, you'll see all the tables have the same percentages, and they've been worked out from a bunch of healthy people, and those numbers get propagated in tables. And we wanted to understand whether that's even valid in a congenital heart disease population. So in general, when we're talking about light exercise, it's about 20 to 40% of the peak VO2. And that generally corresponds, according to the literature, to 20 to 40% of your heart rate reserve added to your resting heart rate, or 40 to 55% of your peak heart rate, and so on. An important point, never ever use the predicted peak heart rates in your congenital patients, especially not Fontan, because so many of them have chronotropic incompetence. You need to work out what this particular person's peak heart rate is from an exercise test. So we went back and looked at all our CPETs over the last few years and looked at what their actual heart rates were for our patients at those percentages of peak VO2, and then looked at what they were using the heart rate methods, the heart rate reserve method or the percentage peak heart rate method. And actually we found that the heart rate reserve method is much more accurate for our patients. The percentage of peak heart rate method tended to really underestimate the heart rate. So you'd be really under training your patients, giving them those guidelines. And interestingly, these results were almost identical for the people with chronotropic incompetence. So we tend to use this now for our exercise prescription. In people with pacemakers, this really isn't validated, and we tend to go by the perceived exertion instead. Another comment I should make is my group in Sydney and my colleagues around Australia, we don't tend to get too worried about measuring saturations. I think that creates a whole lot of panic. Of course, you assess somebody with a maximal exercise test to assess whether anything dangerous is going on, but then encourage them to exercise to a perceived level of exertion. And obviously, if they're feeling unwell, then they should stop. When it comes to exercise prescription, that tends to be something that people are a little less familiar with. And we talk in terms of sets and repetitions. So each repetition is each lift of the exercise. And in general, we aim for each push to be about 2 seconds and each pull to be about 2 seconds. And technique is also really important, and I'll talk to you about that in a moment. But each set of exercises, the less exercises you can do in a set, the harder the exercise is. So for high intensity resistance training, the person would be able to do around 8 to 10 repetitions, and that usually takes about 2 minutes, and then they'd need a rest period. In a higher risk person where we were just aiming for low intensity resistance training, they'd be able to do around 12 to 15 repetitions in about 1.5 to 2 minutes. And we would aim to be designing your resistance exercise to upper limb and lower limb, and we've tended to focus a lot on calf strengthening exercises to help augment those important leg muscles to help preload. Now, method is super important, and because Fontan relies so much on the thoracic pump and breathing, during a Valsalva, if you have a Fontan circulation, cardiac output can fall right off. We really do not want our patients to do a big strain during weightlifting. So it's very important that they're taught to inhale and breathe through all the exercises. We make sure everybody knows that free weights are not a good idea. If you imagine sort of lying down with a bench press, even if you've been spotted by someone above you, it's quite dangerous if someone was to drop a weight on their head. So we do not use free weights at all. This is just a little table that I saw recently in the new ESC guidelines that are a really nice summary. And if you want a little bit more information about the types of exercise involved with different sports, I'd suggest you have a look at that. It's a really nice little summary. So mid-2021, we're going to be recruiting for the first ever randomised controlled exercise intervention. It'll be all across Australia and New Zealand, and we're hoping to involve some North American sites too. So if you're interested, I'd love to hear from you. You'll need to have your own funding, but we're planning to start recruiting around the middle of next year. So that'll give us some really important evidence, because we do need more prospective evidence to help us understand all the things I've spoken to you about this morning in much more detail. So in conclusion, in the setting of Fontan physiology, exercise improves body composition, preload, stroke volume and exercise capacity, and it's a fantastic therapy for mental health and improving quality of life. And observational data suggests that improving exercise capacity may translate to improved clinical outcomes, but we've got to work a little bit harder to address that question. Thank you very much.
Thank you very much, Rachel, for an excellent talk. I really enjoyed the talk. Yes, if anybody wants to ask any questions, either you can unmute your microphones and ask the questions, or type them in the chat and we will ask them to Rachel. So there's one question in the chat that came through the through the presentation. Is there any Fontan specific tips or tricks regarding cachexia or frailty?
Yes, exercise. So I mean, the only evidence we have of what improves that cachexia is exercise, and it is possible to really augment the muscle mass with resistance training. Of course, first of all, it's important to make sure that they're not losing protein in their gut and optimizing all the other things. Make sure they've got an excellent diet. So we regularly, we've dragged in a dietitian who actually works with our liver patients and with the liver transplant service, who gets involved now with our patients. And I think it's much better to have a dietitian who understands your patient cohort than recruiting somebody out in the community that's not used to dealing with these kind of complex issues. So I think optimizing diet's important, but there's really no data at the moment for us to understand exactly what nutritional things we should be recommending. So at the moment, we just recommend a healthy, well-balanced diet that's high in protein. But I think exercise and focusing on resistance training is really important. So
Nauman, I think, has a question. Nauman?
Thank you, Dr. Rachel. I'm one of the ex-fellows from this great center. Very eminent talk, really enjoyed. The quick question is that, as you know, regarding the training which comes with the straining, like Valsalva and kicks in. So one of the adult population, particularly the adolescents, they are very keen to have some, exercise training, maybe some kind of a gym training. So we understand that weightlifting, and which has a very negative impact on the Fontan circulation. But what kind of extent we can give them an advice within the safe boundaries that yes,
yeah,
up to that level you can go, not beyond that. And second thing, if you allow me, the second question is that, like in my setup, we don't have an exercise echo. We usually do the exercise echo with the dobutamine for the other reasons, not for the Fontan patients. So the old methodology that we used to do for pulmonary hypertension, like 6-minute walk test, is there something that we can assess after giving some exercise prescription on the follow-up of our Fontan patients? That would be great if you can answer. Thank you.
Okay. So first of all, with resistance training, so weightlifting is not bad for a person with a Fontan. What is bad is if they're not weightlifting properly. So if they were to do a deadlift and Valsalva, that's not a good thing for them to do. It's dangerous and it's not going to help their circulation. But proper resistance training where they're taught to breathe is not unsafe according to our experience and the literature. So the way to do it properly, if in a trial or if you've got a professional person training them, usually your weights are guided by what's called by doing a strength test. And to do a strength test, you take the, say, 5 exercises that you're going to be teaching the person and getting them to train on. And what you need to do first is work out what their 1 repetition maximum is. So you sit them on the machine and you work out what the maximum they can do just in 1 repetition. But that you're making sure that they breathe the whole time. So say, for example, they were doing a chest press. So once you know what the weight is of that 1 repetition maximum, then you prescribe the exercise training program. So in general, for somebody that's low risk, that can do moderate to high intensity resistance, their repetitions will be at about 70% of their 1 repetition maximum weight. But if you don't have to get that fancy about it, you can just, if somebody can do 8 to 10 repetitions before they need to take a rest, that's about moderate to high intensity resistance exercise training. And then if you're doing low risk, if someone can do 12 to 15 repetitions in that sort of 2-minute period, that's light resistance. So I think traditionally we've all had this thing in our head that weightlifting is really bad, but I think it's just the Olympic deadlift weightlifting is bad, but even in heart failure populations, there's quite a number of really nice studies showing that you actually improve systolic and diastolic function with resistance training. So I think it's got a little bit of a stigma attached to it. And secondly, so you were saying that you don't have, so your way of training of exercise testing at your centre would be walk tests. Is that what you were saying?
No, the assessment of.
Yes, exactly. Yeah.
Yeah. So I think that's okay. I think you need, personally, you'd want to make sure that you've got some kind of maximal exercise testing. So generally in a walk test, the person hasn't sort of gotten their heart rate up enough that you can really understand what they're going to be doing if they were out training intensively in the community. But I think a treadmill test would be perfectly adequate. And we often, in Australia, because we've got people living, out, thousands and thousands of kilometres away, that a simple treadmill test is perfectly adequate. But something maximal where they've been pushed to as far as they can go while being on.
Yeah, I think that's pretty relevant. Thank you so much for answering questions. Thank you.
We have a question on the forum, and Dr. Rosny, I think, want to ask something. So, Erwin, you can ask after I ask the question in the forum.
Thank you, Rachel, for this wonderful talk. A lot of practice advice. That's what we need when we counsel our patients. Actually, I do the same. The patients are very keen to do not only aerobic exercise, but to do isometric exercise. Not only Fontan patients, all type of patients. And usually take a very simple approach. I also tell them that if you can do 12 to 15 repetitions without straining or without the Valsalva maneuver, then you're safe. That's what they should tell the patients. So very simple.
Well, I think that's great. I mean, I think that there's some patients that can probably do more, could be pushed a little bit harder, but even 12 to 15 repetitions, if they're doing 3 sets and doing it regularly, they're going to improve their muscle mass. You will get more hypertrophy if you increase the load a little bit more. And I think it's okay for some people to do the higher intensity resistance exercises, but I think longitudinal, in the study that we're planning next year, we're going to be assessing central venous pressure, liver stiffness, all the things that we've worried about over a 12-month period, and then we can follow them even longer to help us understand. But right now, the evidence suggests we really should be encouraging our patients to to be more active. I mean, I'd be interested, Rafa and Erwin, you see a lot of patients. Have you noticed that that phenotype of that person who has been always active, they're just quite a different species almost to the frailer people?
I have to say that that I noticed that. I have to say that in terms of exercise, I always been very flexible about, in letting any single patient, even as severe as they are, to do some degree of exercise, and mainly those that that fit on the low risk or moderate risk for as similar to your table. It's true, those patients that are more active, or even people that have very active physical jobs, those that works in a physical, like construction or something like that, and you have patients that are Fontan or patients with a severe LV dysfunction, but they are very physical work-wise, and they do better. They do definitely do better.
Yeah,
I think also my impression.
I have seen that. I have a question, but let me just ask the question on the forum. After I have a couple of questions for you. There's a question here on the forum about the role of IMT diaphragm training for the association between the diaphragm fatigue and exercise.
Yeah. So for IMT training, did you say?
Yeah, IMT diaphragm training.
Right. So there's a couple of studies. My colleagues, I think, published the first study, and interestingly, they showed that at rest, stroke volume was a little better, but there was no impact on peak oxygen uptake. And I think I do use inspiratory muscle training, particularly when I've got very sick Fontan patients in hospital that are too sick to be doing very much exercise, and especially perioperatively. I think it's really important. But there's no evidence to suggest that it's anywhere near as effective as exercise training.
So my question, I have a couple of questions. One of them is just along with the one that just appeared on the forum. So how do you do that on a daily basis with your population? So I have two questions. That's how often do you reassess your patients? So when they come first time to your clinic, you just assess them, do an exercise program. So, and how long the program lasts for? And second, do you have any exercise specialists in your clinic that help you with this, or do you do that yourself?
So firstly, yes, we have a clinic, and people can come on the same day and have all their workup on the same day. If they're just coming to Sydney for the day, and we do the exercise test, and then we do an exercise prescription. But I don't routinely keep retesting the exercise test. I would only do an exercise test once every 2 years or so, depending. If I'm worried about somebody or something, then I'll be obviously watching them a lot more closely. Sometimes we have in our healthcare system, you can be referred to an exercise physiologist in the community for 5 sessions. So I will often find somebody that's local to that person and work with them and give them, a sort of summary like what we've talked about tonight, and then they can be trained. I have my PhD student who is an exercise physiologist, and he's finally now been put on our staff, which is lovely. So I've got him to help, and he's now part of the team, and he'll help people. And we're starting to do some more tele-delivered exercise programs, and we've developed some materials to show people how to use things like the gym stick, and we've developed a program for families to help them with games and things like that.
And another question said, do you train? So you explain very well during your talk how do you explain to people, or what is to do how you should do a repetition, and how do you manage to explain that to patients, or how do you approach patients? And because we're doing, unless you do it physically and you have the weight and how do you do that as part of the training?
Well, Well, I usually do a very silly things and show them myself. I use my desk chair and put my feet on my desk to show them like a leg press. But not everybody would want to do that.
I don't mind to do that. Is any other questions from the floor?
Erwin, you were going to say something before, I think.
Erwin.
Regarding your questions, also I echo Rafa what he said, what they also observed. Patients who are more active, are doing exercise, they are healthier. Their mental and physical health is better. And I think it's key that we counsel our patient about the regular exercise, how important it is, not only for the patient, but also for us. That just applies to me. Yeah. And I can give you an example. I had a Fontan patient with moderate pulmonary agitation, and then he had a stroke as a child. He wanted to climb Kilimanjaro 5 years ago, and I did a kind of pulmonary study, and his oxygen consumption was 72%. And then he started training to prepare his trip. And when he came back 6 months later, I repeated the CP study, and his oxygen consumption was 99%. So this tells you how important it is to recruit the skeletal muscles for a better performance.
Yes, I was going to show you actually a before and after of one of my patients, but it almost looks unbelievable on the body composition. I thought it looks like a doctored sort of picture, and I thought, oh, it's almost just, you know, just from simply talking to a patient and explaining to them how, because it gives them control over their life as well, to say, look, this is something you can do to help manage your trajectory. And I think that's really empowering for patients, and yeah, nice to see.
I never restrict patients. That's very important what you mentioned before. I never restrict patients being active. I encourage them being active. Just actually the patient told before, actually successfully climbed the Kilimanjaro then.
Yes, or if you do need to, if you do have concerns, I think it's important to frame it in a way, in a very careful way that focuses on all the things they can do, because it's so harmful to young people.
Well, one thing that I do in just, you know, when just moving towards what I normally talk to them about, you know, the time that will come that you might need a heart transplant, because this is at that day you're gonna be, you know, I'm gonna be the one assessing you for a heart transplant, and the fitter the patients are get to that day, so you can have a Fontan that has a failing Fontan, but it's being a Fontan that's been fitter, it's been fed against exercising, and the amount of muscle mass that you might get up to that point, or that you might lose is while you're waiting for the heart, your outcomes, there are data suggesting that the outcomes are better. So that's another way that I encourage them. So look, this day is going to come. So so it's if you start to do these things now, it's an investment for the future.
Yeah, it's a really good point. I have to apologize. My dog was being so funny. He was like jumping around, and I got very distracted at the beginning of the talk. I'm sorry.
Okay. So is any other questions on the forum? If there's no other questions, we're gonna let you go. It's 11 p.m. there. So thank you very much for, as I said before, joining us, and excellent talk. It's been brilliant and really didactic and instructive for us. So thank you very much, Rachel, and see you around.
Very much for having
good
me.
night and good morning and good evening, wherever you are in the world. Okay. Bye-bye.
Bye.
Bye, Rachel. Bye.
Yeah, bye, Rachel. Have a nice weekend. Bye-bye.